be really interested to know, Dr. Greenberg, in all the years of your focus here, like how many more resources are available than when you started? And how many people actually even take advantage or to know about that in the different communities?
Oh, that's a big question. I mean, the world has changed since I started in the field. Um, there's it's unquantifiable. Um, there are medical practitioners who understand this disease that did not exist in the mid 80s because we just didn't have the knowledge about the disease. I did a the amyloid that is the pathological hallmark in the brain, one of the pathological hallmarks. As a young scientist, I was one of the first people to clone the gene for that protein. All right. And this was 1986. And the first international Alzheimer meeting was held in
I was 16.
I was a little older. First Alzheimer International meeting was held 2 years later, and youthful hubris, we all got together and said, well, now we got this gene, we're going to have this disease licked by the turn of the millennium. And Mother Nature had a good chuckle at us. It's really in the past 5 years that there have been fundamental advances that are quantifiable. And when you look at these drugs that have been approved, and I have a lot to say about the statistics that went in. I personally think that there's a lot that's hiding underneath the statistical data, and we don't need to go into that right now. But what we do know is that these drugs slow down the progression of the disease. So what does that do? It opens the window, opens the door for combination therapies to bring in other drugs that on their own would not be effective, but which in combination, once you've started to slow down the progression of the disease, may actually be what we need to turn the corner. And that's not going to be just one drug because there are a lot of comorbidities, but that's where precision medicine is really going to come in, and we're going to be able to dial what combinations people should be taking. And let's think about that for a minute. How many diseases are we very familiar with where that's exactly the case?
Hmm.
Yeah, I was thinking that you were sounding like an oncologist
Yeah, right.
almost, right? Just really specific. And that's what people want and need out of their healthcare, something specific for me, right? And what would be people's response, do you think, Doc Griggs, to what Dr. Greenberg was saying? If your neurologist is saying, I can mix this for you.
So, so let's go to let's start with expanding the average visit from 6 to 7 minutes to 15 minutes. Let's start with going back to now again. I was only 16 in '86, but let's go back when starting med school. They told us, you got about an hour and a half. You can't get to know if you talk to the patient 100% of the time, they will tell you the problem. But about 75, 80% of the time, if you talk to them long enough, they'll tell you the solution. Well, doc, I have a headache every time I do this. Really? Well, why do you do that? Well, I do it. I do it every time I come, and my daughter is she's not doing what I ask her to do because I yell at her. Well, have you ever tried talking nicer? I never thought about that. Do you do that when you don't yell at her? No, I don't. Well, doc, you're brilliant. I don't think I'll start hitting my head. But we don't have time to get to know each other. We don't have time to build that trust anymore. We went from home visits and paying, I think it was Doc Hollywood. That's a nice pig, paying with pies and pigs. So now 6 to 7 minutes, and you're telling someone a life-changing condition that will change the dynamics of their family forever in 6 to 7 minutes, and you don't have time to explain it. So having these conversations, being able to literally take time to answer, let that patient give you their understanding of what you said. I know this is what I said. Can you tell me what you heard me say? And then now let's work together on how we can get to this solution. Now, if you're talking about something that fans out, that can be multifactorial, that can be addressed in a number of ways. So I know that you have Alzheimer's, but this drug can slow it down. And then we can treat these other contributing factors like your hypertension, like the fact that you have uncontrolled diabetes, let's talk to your social worker and talk about your environment. You're working third shift. Well, is there anything? Well, you need to get a GED. Well, there's a GED program and there's a social program that'll help you pay for it so you can get a day shift to buy a car to come to the doctor that can lower this and lower that. And if we just need to spend time, stop moving so fast. The information moves faster than human connection does. And we have to dial it back to the human connection so we can be effective in trying to help people, heal themselves as we try to help them as doctors. Does that make sense?
You're making a lot of sense. I think you're also talking a lot about reimbursement issues, and how we are all structured to practice, right? There's a reason I chose to be a hospitalist, and it's because I want to have longer conversations with my patients. And believe it or not, I do get to have those conversations because I run my schedule for the day. You give me my list of patients, and I know who needs a 3-minute, 7-minute conversation, and who needs a 40-minute conversation, right? But I think that when you're talking about outpatient medicine, primary care physicians, it is very difficult for them to navigate that space and do all those things. I think everyone would love to have a social worker and a case manager. I am a huge advocate of case managers and social workers. Like I wrote a whole chapter in my book about get every minute you can with the case manager and the social worker, because those are the people who know what's in the community. Dr. Greenberg said that the things in the community are innumerable. And I believe him, because while the medical institution has been struggling with how to start to think about how to support these patients, their family members and their community has had to do the work. And they have already risen, right? That like adult daycare type centers, in the Boston area, there are people who have adult daycare centers for different languages, right? Knowing that their patients with dementia will revert back to a language that maybe was their first language, right? And I have a friend who is the medical director for a Russian speaking dementia unit here in the Boston area, right? So the community has already been doing the work. Oftentimes we in medicine, I forgot what it was in med school, we're pre-contemplative. We are often stuck thinking about how we're going to do things for patients, and the community has already had to do the work.
So to your point though, how effective do y'all think it would be if we started asking the patients to bring an advocate to the room with them? If the community's already doing the work. Once that family member comes and finds out that Eric keeps saying he's good, he's fine, and he's not fine, that wife, that sister, that daughter, that cousin, that brother, that they turn into social worker, chef. Okay, what do we need to do? Imagine having them earlier in the conversation. I try to advocate for people not to go to the doctor by themselves because of the cortisol response and the accountability, right? Mm-hmm. If we educate people, just because I can't change my own oil, I can't install a car radio, but that doesn't mean that I can't understand what it is that they're talking about and talk someone through the process. We're talking about medicine and the human body, giving it to loved ones, giving it to people that actually genuinely care, making a team with them. They pull in. You've seen it happen how many times in the area of brain health? When the families come in, they start taking, I've done it in my own family. You take a shift, I take a shift, and it's all different generations. So again, it's opening up the door for conversations so the information that we have, we can give to them. And though one person might not be able to handle it, they can handle different aspects of it to help surround those loved ones. And again, encourage the family to get involved in healthcare and clinical trials and really the care of the community and their loved ones.